Good morning, this is Dr. Duke, and I'm going to give the presentation for this week's lecture on substance disorders. Alright, to get us started, I wanted to go back and just so you guys have a little bit of etiology, understanding / the patho of what leads to substance use and mainly, predominantly, that addiction, that maybe it's that addictive personality or the addiction in itself. So addiction is characterized by compulsive drug craving, seeking, and use that persists, even when there are negative consequences, even when maybe they've lost a home, lost a job, lost a relationship, the action, the behavior continues. So the reward pathway, it's part of the brain that we theorize has a relation to addiction. The reward pathway involves several parts of the brain, the ventral tegmental, or the VTA, the nucleus accumbens, and the prefrontal cortex. When activated by rewarding stimulus, for example, food, water, sex, so forth, information then travels from the VTA to the nucleus accumbens and then back up to the frontal cortex. So maybe there's something that is rewarding that part of the brain, that's activating that part of the brain that makes you want to come back or use that same substance. All drugs that can lead to addiction increase the dopamine, or in other words, an abbreviated DA, in the ventral striatum, also called the nucleus accumbens. And that's a main thing to kind of keep in mind. All drugs that can lead to addiction increase dopamine, okay? Because there's some of these drugs, as we're going to get through these slides, but wait a minute, Dr. Duke, those are CNS suppressants, so I don't understand how but they're not a stimulant. Like, how are they increasing dopamine? It's the way that they work in a person's brain, how they react to that person. Reinforcement. So the brain-based changes in structure and function can lead to addictive behavior. If there are some changes, different functioning, okay? Process for positive and negative rewards is physiologically linked to memory function. What do you remember most? Is there negativity that you remember about that drug? Is there positivity that you remember, like that, oh, when I did this, this happened to me, I felt this way. Or I did this, it made me feel horrible. And we're going to remember that, right? Physically, also our body's reaction, okay? So changes appear in any drug of abuse. Yeah, absolutely. Changes in personal behaviors, maybe physically, psychologically, we can change. The reinforcement results in that feel-good sensations when a drug of abuse is used, and in that feel-bad sensation when the drug exits the body. So all of a sudden you have this wonderful high and you feel great, and now it's gone. And great, now it's back. Now I'm back to feeling down and depressed and no energy, okay? So those positive rewards of reinforcement result in social rewards, and this can include disinhibition, so kind of doing things without thinking, not ever caring. Maybe you've always been a shy person to yourself and not really outgoing, but when you drink alcohol, you're more outgoing and you're talkative and you don't really think about others and have to worry. There's maybe a sense of euphoria and happiness and everything is wonderful and not as anxious. And some people feel this maybe when they smoke a cigarette. They don't feel as anxious. And so that is their whole part of that, oh, I need another cigarette. I'll need a cigarette. I need to step outside and have a cigarette is my way to cope with my anxiety. So these positive rewards are mediated by the dopamine pathway. Okay, let me say that again. Positive rewards of reinforcement are mediated by the dopamine pathway. I say that because the negative pathways that are averse, such as, okay, again, now I don't have the drug and now I'm anxious and I'm back down to depressed, those are mediated by the GABA pathways, okay? Reinforcement occurs in the ventral tegmental area and the nucleus accumbens of the brain, collectively called the reward center, okay? Whether or not is that positive or negative reward, right? How do we perceive, what are we getting? Okay, what is our brain getting from that drug? Dopamine release within the reward center is enhanced by further release of natural morphine-like neurotransmitters called neuropeptides. The neuropeptides further enhance the reinforcing pleasure experience by the individual. So with repeated drug use, the dopamine system becomes increasingly synthesized. Okay, so more and more use, more and more synthesized to that drug. All right. And this is going to be very, very important to that play is when we talk about later here chasing that high and never getting quite the same effect that you did before. Eventually associated drug use stimuli can cause dopamine release, leading to reinforcement of use and often increased drug use. And there we go. Because, again, chasing that high, and do I need more to obtain the same feeling that I once had? So different types of substance addictions: stimulants, hallucinogens, nicotine, marijuana, alcohol, opioids, and even sedative hypnotics. So just to kind of make sure that we understand some of the terms, if you hear the word tolerance, okay, what does tolerance actually mean? It's when the body becomes less responsive to the drug with repeated exposure. Withdrawal: painful physical and psychological symptoms that follow the discontinuation of a drug. So, all right, let's stop. Tolerance: when the body becomes less responsive after repeated exposure. Okay, so maybe you used to get a buzz off 1 or 2 drinks, and now it takes a 6-pack to give you the same buzz. Okay, you've built a tolerance to that substance. Withdrawal: okay, I've had it, now all of a sudden I don't, and now physically, psychologically, I can tell I am withdrawing from, okay, maybe it's after you're having a hangover, right? Essentially it's withdrawal, you're throwing up, feel awful, headache, okay? That is, your body does no longer have that substance, and you're feeling those effects of withdrawal. So substance abuse. And I want to make sure we are deciphering and you're being able to differentiate what the difference in abuse versus dependence. Okay, so substance abuse, the maladaptive pattern of substance use leading to clinically significant impairment or distress manifested by one of the following for at least a 12-month period. So they have to have some kind of recurrent substance use, okay, failure to fulfill their major obligations. Maybe they've been late to work several times or no showing at school. Or they're not getting their work functions done, home, they're failing maybe at parenting, falling asleep on the couch because they're currently using substances and the kids are running around unintended. Reoccurrent substance use in situations that can be physically even hazardous. Maybe being behind the wheel. Maybe you've got a DUI, or just several times they've taken that risk and not even thought about it. Maybe they operate a forklift at work in a position and they're doing it more impaired. Reoccurrent substance-related legal problems. Maybe there's been arrest for disorderly conduct, for maybe having a fight in the bar. Maybe there was, just you were walking. We just dings my brain having a patient who was unfortunately taken in because then they were drunk, but were walking naked outside in the middle of the street. So indecent exposure, being arrested there. Continued substance use despite having persistent and recurring social and interpersonal problems. Your family said something to you, your partner said something to you, work, school, and just you continue, to have the behaviors. It's very evident. So maybe you're arguing more with your spouse. You're physically getting into fights at the bar because of it, and you're aware it's really causing a problem in your life. So substance abuse, okay, using it to the point to where it is getting in the way of my obligations, work, school, home, okay, getting into situations that are physically hazardous, legal problems, and doing it despite you're aware, despite that you just got a DUI and you went ahead and you got back in the car and you did it again, despite that you're losing your wife and you're in having to go through marital counseling, or you may lose your children, your wife because of this, or husband, and because of this drinking, you continue to do it anyways. All right, now it's dependence, okay? So use was we're using more than we should, right? Well, dependence, so we've got the maladaptive pattern of substance use once again causing distress, impairment, okay? Now, if 3 of them were following in a 12-month period, there's got to be presence of tolerance. Here's where our terms come into play, okay? So this is someone also that, again, not 1 or 2 beers, they've had to drink more to get the same effect. Again, maybe it wasn't, not just 1 puff of marijuana. Now I'm having to smoke more often every day to get the same effect, or smoke more to get that high. Presence of withdrawal. So this is someone who literally has been through withdrawal before. And maybe it's benzodiazepines and been using more along the way because it just wasn't enough. And I ran out of Xanax a week before I was due to refill, and actually went through withdrawal symptoms, which we know from the last chapters too, it's very, very dangerous. Okay, right? Seizure risk there. But So they've gone through tolerance, withdrawal. Substance is often taken in larger amounts over a longer period than intended, and that's pretty much talks right there. It backs up the tolerance thing as well. Okay. Persistent desire, unsuccessful efforts. So maybe they've actually tried to cut down. They've really tried to stop, and yet they continue to do it anyway. It's just hard. They go back to it and they find themselves, and maybe have a good week, and I'm grateful, like, hey, I'm doing great. I'm down to like only one drink and it's getting better. Or, if it's cigarettes, I'm down to 6 cigarettes today and I'm used to a pack a day. And then maybe something even little stressful, something happens, it triggers, and you go right back to where you were. Okay, so being able to unsuccessful, and this I should have posted in the presentation, but CAGE, you guys remember if that's maybe from nursing school, but the CAGE questionnaire, have you ever tried to cut down? Okay, have you ever been annoyed, is the A, with someone telling you it's very, they can see that and they're trying to tell you it's a problem and you're frustrated at them for even telling you and you're aware. Okay, guilt, do you feel guilty that you are doing it in the first place, and maybe you do need to change? Maybe this is where this comes into play, where now you're like trying to cut down, okay, but you're having trouble. And then E in CAGE, an eye opener. Have you had to wake up and have another beer to get going, or a cigarette just to keep you out through the day? Okay, so have you ever tried to cut down, been annoyed from others, letting you know it's a problem, feeling guilty, or an eye opener is your CAGE questionnaire. Okay, but and maybe this person also, they're spending a great deal of time trying to find ways to obtain the substance. And unfortunately, this is a sad thing, but doctor hopping, going to multiple different doctor's office, driving long distances. They may live in Columbia, Tennessee, and they're going to drive out to Memphis and different physicians and try to use different pharmacies so that you don't know that they need to obtain the substance, and wanting to pay cash, or going through friends of theirs and that they shouldn't to get the substance. Unfortunately, people are prostituting themselves just to be able to get $10 to pay for a crack rock. Okay. Important social, occupational, recreational activities are being given up. So you're actually beginning to lose things at this point. Maybe it is your family. You're losing those relationships because of the dependence on this substance. Maybe you're taking all the money from your own family and you're having a hard time paying your bills, so you may be at risk of even losing your home. And again, you're continuing the substance even despite knowledge of the problems that it's causing you. You're continuing it anyways. Okay. So alcohol-related disorders, just some more, I guess, terms to understand too. And it's always impressive. I enjoy this lecture, especially when you're live and people realize, oh my gosh, I've had a binge drinking episode. Okay, binge drinking is 5 or more drinks on the same occasion during 1 or more in the past month. So here I'll just talk about the man who had a 6-pack. Okay, he technically had an episode of a binge drinking episode. Okay. So heavy drinking is 5 or more drinks on the same occasion for 5 or more days in the past month. So if you're a heavy drinker and have partied hard every Friday and Saturday night for the last month, then you're considered a heavy drinker, actually. Okay. So it not only maybe you've had 5 or more drinks in one night, so now you're a binge drinker, heavy drinker, okay, but maybe you've just had, it's like I said, mainly your weekends, it's cookouts, but throughout the day you've accumulated, well, now I've had a 12-pack of beer, you're considered a binge drinking episode. And if you're doing it, like I said, more than 5 days in the month, a heavy drinker. So when we're talking to patients and they're like, well, is there something wrong with having a glass of wine at night? I mean, is it so bad that I have 1 or 2 glasses of wine? It's just some teaching for us as providers is how to teach, well, here's what we know is considered more low-risk drinking and less likely to lead to dependence, okay? And that is no more than 4 drinks on one occasion or 14 in a week for a man, okay? So that means, like, if you're just going to watch the ball game on the weekend on a Saturday night and you want to have a few drinks, okay, that's your 4, right? No more than 14 in a week. So if you're one of those that wants the glass of wine, wants 1 or 2 glasses of wine every night with supper, okay, just be aware that comes out to 2 a week. But if you're going to drink the wine during the week and then watch the big ball game, just think about those numbers and adding it up. Maybe you want to reduce to 1 glass of wine during the week if you're going to have a couple drinks on the weekend. For women, no more than 3 drinks per day. Okay, again, maybe it is out with the girls or having margaritas or again with a ball game, and then no more than 7 in a week. So again, think about that, okay? That glass of wine every day, or if we're going out this weekend, okay? Just helps to put a perspective of an amount so that a patient can actually relate tie that amount with the risk factors. So alcohol disorders, alcohol intoxication, recent ingestion of alcohol, clinically significant maladaptive behavior, psychological changes. Okay, they may be sexually more increased sexual behavior, aggressive, changes in mood. Some people get very quiet. Some people get very giddy, not thinking correctly. Yes, can this impair your social occupation at that moment? You know, you're not thinking clearly. You're drunk. In other words, okay, this is drunk. One or more of the following signs may have slurred speech, incoordination, unsteady gait. Nystagmus, that's kind of where, if you guys remember, that's kind of where the eyes can kind of twitch back and forth, okay? Impaired in attention or memory, and even stupor or even into coma, depending on the amount that you drank. Symptoms are not, of course, yes, and you're not having these things because of a medical condition or anything else. It is because you've ingested the alcohol. Now, on the opposite end of that, we're talking about intoxication, but withdrawal, okay? So cessation or reduction of alcohol use has been heavy or prolonged can cause you to go into withdrawal, okay? So 2 or more of the following develop within several hours to a few days. And you're going to learn here in just a second how important that is, that timing, okay? The timing of when their last drink was. So they can have autonomic hyperactivity, sweating, pulse rate greater than 100. Alcohol works on the brain as a central nervous system depressant. So it's calming things down, respirations, heart rate, pressure. If that's been jerked away from you, then what is your body going to do, right? It's going to do the exact opposite, okay? So pulse rate goes up, pressure can go up, all right? Respirations can go up. Increased hand tremors, not be able to sleep, nausea, vomiting, transient visual, tactile, even auditory hallucinations from withdrawal, agitated, anxious, and even seizures. Again, because if you've had prolonged heavy amounts on your brain that's been suppressing that electrical activity in the brain, all of a sudden it just jerked from you, then think about your brain's reaction. What may happen on the other end of that? So here's where I was saying it's very, very important. Everybody is, hopefully at one point or another, you've probably heard of DTs, okay, or delirium tremens, all right? So DTs are considered medical emergency and can result in death if not treated. Usually the state of delirium peaks 2 or 3 days, and that's why I said the timing is so important. 48 to 72 hours after your last drink, or after you've stopped, okay? So when they're presenting, if you're emergency room nurses, you're probably aware of this, right? Or you've worked any kind of emergency trauma background of asking a patient when was their last drink. Because do we need to be aware that they may be having a seizure on us? Could they go into DTs? All right. We need to be aware, when was your last drink? 48 to 72 hour window. Very, very mindful. Maybe the patient just comes to the ER and like, well, my last drink was yesterday. Doesn't mean they're not at risk. They may not be showing any symptoms yet. Okay. But symptoms include autonomic hyperactivity that we just mentioned. So more diuresis, elevated blood pressure, heart rate's increased, a disturbance in their sensorium, they're disoriented to time, place, kind of clouding of their consciousness, not thinking straight, can be hallucinating, even fluctuating consciousness from hyperexcitability to almost lethargic, so changing there. And that is actually one of the things that we learn as we get to older clients and things throughout the course, is that being able to differentiate like delirium versus dementia, and that fluctuating levels of consciousness is going to fall more under that delirium, okay? They can even be having delusions, paranoid, people are out to get them, agitated, and even running a fever. Chronic alcohol use consequences, okay? You can actually develop amnesia, an alcohol amnesic disorder, where after heavy prolonged drinking, I mean, because of the poor nutrition or maybe the effects of the alcohol in the body, that you have issues obtaining new information, recalling even remote things, neuropathy, unsteady gait, and myopathy, muscle weakness because of the alcohol. But that amnesia, not being able to remember, maybe literally missing periods of time in your child's life, not remembering soccer games or etc., due to the alcohol. And even worsening alcoholic dementia. I've seen this one time at the state hospital in practice where a patient actually had dementia that we believe is caused from chronic alcoholism. And he also had one of those things too when I look at assessment, and I don't know if anybody has ever seen this, but we used to call it the alcoholic nose, where he had a very large nose. It was very dimpled. as well. And sometimes that was one of the things I learned from my preceptor, one psychiatrist, who was saying that long-term alcohol use, if you'll look at their nose, sometimes you can tell that they were a very heavy drinker. And it was interesting why it causes that. But alcoholic dementia, actually losing intellectual ability or severe enough where you cannot work anymore, you can't function as well, literally like a dementia client. Memory, thinking, judgments changing. And it can be mild, but even into severe or even permanent brain damage. And for this gentleman, a lot of times discharged from the state hospital, we're looking for an outpatient or facility, group home, ACT team somewhere. In this particular case, it was actually going to be discharged to more of a nursing home because of the level of damage from the alcohol. So chronic alcohol consequences, there is the Wernicke's encephalopathy and Korsakoff, you've probably maybe at one time heard. So Wernicke's is actually a thiamine deficiency or vitamin B1, okay, deficiency leading to decreased mental functioning, paralysis, weakness in one or more muscles, ataxia, nystagmus, and even mental status changes. The Korsakoff psychosis, and you can have Wernicke's, Korsakoff as well. You can have both, okay? But the Korsakoff psychosis is thiamine deficiency characterized by persistent learning and memory problems involving disorientation, delirium, gait, short-term memory loss, and even neuropathy. So this is, again, you've drank so much that your brain actually goes into, and you think of the word encephalopathy, I mean, there has literally been brain changes, swelling, okay, to the brain due to the alcohol, okay, due to these deficiencies also in these vitamins. And so we've got to get you some B. We've got to start thiamine and get it in their system to try to start helping with some of these symptoms and make sure that we're getting them out of the alcohol. All right, to kind of go from a jump from a CNS depressant to CNS stimulants, okay, things that stimulate the brain. Cocaine, crack, amphetamines, meth, caffeine, nicotine, okay. Yes, caffeine is still essential nervous system stimulant. A lot of people feel like, oh, I've got to get up. Do not talk to me until I have my morning coffee. If that's something that people may say or feel like maybe that's that dependence on that particular substance to wake them up and get that same feel. Common signs, if we're evaluating to know what type of abuse and this person's maybe acting out and changing behavior, and we're trying to figure out what's going on. Dilation of pupils, and I want you to remember that because we're going to be the reverse here in a minute. Dilation of pupils. I think about it as stimulated. The person is very stimulated. They're going. They're on edge. They've got something that's heightening them, and so their pupils are dilated. And I think of eyes being big and stimulated. Dryness of the oronasal cavity, especially if they've been snorting. Okay, excessive motor activity. They're just can't sit still. Very restless. Okay. Crack and cocaine. When crack is smoked, it actually takes in effect within 4 to 6 seconds, producing a fleeting high for 5 to 7 minutes, followed by a period of deep depression. So then again, this reinforces the addictive behavior of, wait a minute, I need to do this again. It didn't last long. Wait a minute, I got to do this again. I got to do this again. And so that euphoria, that stimulation that you feel, very, very, very short-lived. Okay, so unfortunately, chasing the high. Symptoms of intoxication, if you're having too much, tachycardic, obviously it's a stimulant, right? Tachycardic, dilated pupils, elevated blood pressure, nausea, vomiting, insomnia, can't sleep, you're stimulated. Grandiose, can be impair your judgment, restless, and even cause you to be stimulated enough to cause seizures and go into convulsions. All right, let's also talk about club drugs, okay? So I include some of these things just because in psychiatric practice, you may be dealing with patients, especially if you decide to work inpatient or you're doing a psychiatric ER, or so forth. You're going to be those, especially for you ER folks, you're going to be the first ones at the door to see them come in, or an inpatient where they're more acute. Even outpatient, as we're noticing things aren't quite right, there may be some use that we're finding, and it makes sense for piecing those puzzle pieces of what's really going on with this patient. Ecstasy or MDMA is a prototype of a class substitute by amphetamines, okay? So it also includes MDA or otherwise love, but it's basically a prototype of an amphetamine, okay? Produce subjective resembling feelings of the stimulants, gives outpouring good feelings and others in the world around them. But during this time, they'll be extremely sensitive, hyperactive, inexhaustible energy, like never-ending energy. Their pupils are dilated, but impaired reaction to light. And a lot of times if you'll see, when you say club drugs, it's because it's been more in the dark lights or there's different strobe lights. They're not in the bright light because they're more sensitive to light when they're on this drug. So they like the darkness, the club scene, okay? Or they've been associated more with the club. It can have elevated temperature, pulse, blood pressure, diaphoretic, and even bruxism. If you don't know bruxism, that's like where your jaws, like your teeth actually can lock, and not being able to relax your jaw. Now, these patients must drink, or people, okay, must drink large quantities of water during MDA to prevent dehydration and hypothermia. Do you think that that is on their mind? And most of the time, what do you think that these patients are probably actually drinking instead of water? They may be drinking alcohol, having some drinks, okay, having some shots at the bar with their ecstasy. So here we are on something with alcohol that's actually more of a diuretic on the body. At the same time, they're doing the ecstasy, and that is actually where we get a lot of deaths with ecstasy, is because they are not keeping hydrated during the time they're using. And I don't know if you guys have ever heard this when it comes to alcohol intoxication even too as well. They say that if you're going to have an alcoholic drink, if you'll follow a glass of water with every glass of alcohol that you have, it can prevent you from having the hangover effects because you're not getting that dehydration effect. But again, when you're out partying and you're having fun or beer pong or whatever, you're not thinking, oh, I need to go drink a glass of water to keep myself hydrated, okay? Now, what's interesting about ecstasy is after it wears off, people actually will go into a deep state of depression lasting 3 to 4 days. And then if the drug is continued, they continue to do it. Eventually, ecstasy actually can completely deplete your entire serotonin stores. So, whoa. Like, we look at these drugs, and I've had people ask me, well, wait a minute, can we not give them an SSRI, a selective serotonin reuptake inhibitor? But you have to stop and get them to think, wait a minute, that's reuptaking the serotonin that you have. If you're depleted, if you completely have no more serotonin, how's an SSRI going to work? It's something to really talk with patients and educating if you're seeing those who are using ecstasy in practice, is to educate them that once that's gone, it's gone. And psychiatric medications are not always going to be that choice, because if you don't have the neurotransmitter, the chemical there, then how can we keep it in your body? All right, hallucinogens. LSD intoxication, LSD, PCP, they're falling under hallucinogen. Peyote, mushrooms, shrooms, what people call it, all falling on these hallucinogens. But under intoxication with LSD, you can have, the pupil dilation, tachycardia, diaphoretic, palpitations, tremor, intoxication. The behavior is the big thing, okay? The feeling like you're going crazy, paranoid, marked anxiety, depression. This is very interesting. Synesthesia, colors that are heard or seen. So you actually may see colors, but you can hear colors. Now, I've never heard a color, so I couldn't tell you what purple and blue, what's the difference in how they sound. But during the use of this drug, they're hearing colors. Depersonalization, actually feel like almost an outer body experience, hallucinate, and even grandiosity as well. PCP intoxication, and this has been a while back. I don't know if many of you remember, but there was a gentleman that was actually accused with a couple incidences. But there was a gentleman that was accused on a beach for actually attacking a man and for cannibalism and actually eating a man's face. And what they found out that comes to was there were two things involved. One was the drug use, okay? I think there was whether it was bath salts, which is, again, more amphetamine salt version. PCP, it was PCP in the combination with the dehydration that the man reacted. And there was another incident, I think, not too long ago, where a homeless gentleman got attacked by another man on substances as well. So under this influence, they can have the vertical or horizontal segments, and that's interesting. And I've never seen the vertical. Increased blood pressure, pulse, temperature, ataxia, that rigid muscles can even go into seizure, blank stare, but can be very assaultive, impulsive, belligerent, okay? Even to the effects of very bizarre, like eating the man's face. What was we don't understand. What was the purpose of that? Like, what alluded to that to cause that violent, okay, regressive, violent behavior? Can even be, maybe they were hallucinating, paranoid. We're not really sure. but it can cause you to do things that you don't quite remember. And I had a picture used when I taught BSN program where a gentleman decided on PCP that it was a good idea to take he actually broke a mirror and took the glass shards and decided to actually cut off his face. And this is not to gross anybody out, it actually fed it to his dog. And the story was, it was just trying to wake people up that this gentleman was not thinking right-mindedly. They were able to get this gentleman. They were able actually to pump the dog's stomach, and the dog was okay for people who care about the animals, and be able to get the pieces of it and put back together what they could of the gentleman's face. But coming back and coming off of that high and coming back to reality and realizing, what did I just do, and not remembering what happened or why that was a good idea at that time. All right, opioids. So these are going to work again. Now, opioids, alcohol, barbiturates, benzos, things like that are going to fall in our central nervous system depressants. But remember when we talked about the reward pathways and we said the increase in dopamine? So opioids are generally going to do everything physiologically to the body to depress it. But sometimes people get more of a stimulant effect off of these medications. And that's where I mentioned about the increase in the dopaminergic type feeling, because some people, that's part of the thing of addiction to opioids, is they feel good on pain pills. Like, that's what helps them be more talkative and outgoing and things. That some people that take them are just, oh my gosh, that makes me so sleepy, I can't tolerate that. And again, it's just how the body is processing that drug. But signs if we're intoxicated looking physiologically at our patient is that they'll have very constricted, small pinpoint pupils, okay? So stimulants, I'm very stimulated, I'm dilated pupils, all right, with amphetamines, meth, crack, cocaine, LSD, and PCP. With opioids, okay, and an opioid in particular, people unfortunately misperceive heroin as an amphetamine. It's actually an opioid, okay? With heroin, Lorcets, Norco, things like that, then we have very small pinpoint pupils if we're intoxicated, okay? Decreased respirations, because remember, physiologically, it's depressing the body. Drowsiness can happen, decreased blood pressure, slurred speech, and even psychomotor agitation. Now, I kind of categorize what is my withdrawal, remembering am I withdrawing from opioids. So signs of withdrawal are a lot of times flu-like symptoms is how I remember those. So flu-like, I have maybe a runny nose, I can't sleep good, I'm irritable, runny nose, I'm sweating, that cold, clammy skin, chills, fever, nausea, vomiting. It's like I have flu-like symptoms, cramps, muscle aches. That is going to be your symptoms of your opioid withdrawal, okay? Opioid withdrawal, I'm not going into seizure, I'm not risk as much the alcohol, but I have these flu-like symptoms. All right, so now if we're intoxicated, we've just really had too much of the CNS depressant, okay? So we already said the symptoms: slurred speech, incoordination, unsteady gait, drowsiness, impaired judgment, memory. This is basically like alcohol intoxication, right? Very, very similar. It's a CNS depressant. Now, effects of overdose from a CNS depressant. Now we've overdosed to that point where, yeah, you can completely suppress your heart and lungs to not work. You have a heart attack, respiratory depression, not breathe. Respirations are down to 6 a minute because you've got so much heaviness on you, okay? Go into a coma, shock, even seizures, and even death. So goals and treatment for substance use. There are two major objectives for treatment. And one thing is detoxification, the safe removal of chemical from the body. And usually, depending on the substance, but particularly alcohol, you can actually detox from alcohol within about 3 to 5 days. They do put the person on a CEWA protocol, those of you that worked inpatient on the units, whether it's ICU or you possibly may have started as early in the ER and it's well on the floor. We're looking for those symptoms of withdrawal and kind of maybe it's a benzodiazepine such as Ativan or Valium that is prescribed to help with these symptoms and to get through this withdrawal period. But it's not a continuation of forever. We're not moving from one drug to another. Other pharmacological interventions we can do to help control the behaviors and what's missing. Maybe they need that thiamine replacement. Rehabilitation, obviously rehabbing, because just because you're detox, it doesn't mean that you're not going to go back, right? Oh, this is a horrible experience, I'll never do this again. But in reality, go through and actually break through that denial, what actually is perpetrating or leading to the illness in the beginning. So clinical management. Now we get into more of the pharmacologic type things and things that we need to do on our side as providers and part of this course. So one thing obviously is rule out. Make sure there isn't any medical causes to this. Is there any other factors, anything else that could be leading to some of these symptoms, or do it truly drugs at the end of the day? Okay. Do we already have an underlying psychotic disorder and that's why we're using the drugs? You know, rule out what is going on with our patient. Okay. To receive treatment or not to receive treatment. 80–90% of people who require alcohol treatment do not get it. Yeah. I mean, maybe they've tried on their own. Maybe they just refused. And so it's just multiple different reasons, but a lot of people don't get the actual treatment that they need. So maybe it's lack of diagnosis, maybe it's lack of referral, maybe it's lack of access to services for you guys in very rural areas. There's just nobody else to help, so you never sought the services. Maybe there's a stigma there and not unwilling to admit that there is a problem and don't want to be seen coming out of an AA, and so you don't go. Or maybe there's a genetics of addiction, and because maybe your parents also have addictive traits that you have picked that up and you're more predisposed to having more issues with getting over substances. Now, clinical management differs on substance-related syndromes. So, depending if it's acute withdrawal, acute intoxication, are we doing long-term sobriety maintenance, relapse prevention? How are we going about this goal or this objective? Alcohol withdrawal carries a high risk of mortality. Okay, so obviously, the earlier we can identify these patients, again, assessing, right? When was your last drink? Okay, putting them on CWAB, doing protocol. Hopefully, we can prevent deaths from these patients. All right, so let's talk about medication-assisted therapy for MAT. So the FDA has approved several different medications to treat opioid addiction and alcohol dependence. A common misconception associated with medical-assisted or MAT, okay, is that substitutes one drug for another, and it's not. So these programs are not supposed to just, hey, you're going to come and you're going to get your methadone from us, and so you're no longer going to be on pain pills, but you're going to be on methadone. So we just substituted it. But in reality, there's so much more that's supposed to happen with these programs. You're actually supposed to, when you're coming to get that, or whether it be Suboxone, you're actually supposed to come in the clinic, and not only are you getting these pills, but you also have to see a therapist, and you also have to attend group, and you're getting these urine drug screens, and we're following you more closely. And hey, by the way, we're also going to be looking at your psychiatric illnesses and things so that we can treat these comorbidities and not just giving you a pill for a pill. So you're actually agreeing to a program and not just going to another pill. But what's really sad is it's a good thing that more people are being able to write Suboxone, but unfortunately there are even primary care settings that are just writing it so that they can give them Suboxone, but they're not really going through the whole plan, the whole treatment, okay, by having the group and the therapy and the ways to get through this. And maybe this won't necessarily have to be a lifetime thing. For some patients, they may have to be on this for life, but they're not getting the services that they need. So, as one negative thing. But research has shown if they're coming to MAT and they're doing it correctly, okay, then there can be, at the proper dose, medications, no adverse effects on their intelligence, mental capability, physical functioning, employability. A lot of times these people are having to get up and come daily for their dose, or they're getting a limited number of prescriptions or pills, okay, so that they're not likely, they can't overdose with these medications or take more and run out and make another substance abuse, or having to come and be compliant with their treatment. So opioid medications or opioid dependence medications we can use. So methadone, buprenorphine, and naltrexone. They are used to treat opioid dependence and addiction with short-acting opioids such as heroin, morphine, and codeine, as well as semi-synthetic opioids such as oxycodone and hydrocodone. So methadone, buprenorphine, and naltrexone are things we can use for opioid dependence. All right. Now, as I mentioned, people can safely take these type of medications in MAT, okay, medications programs for months, years, or even a lifetime if they have to. If this is the one thing that's going to prevent you from going back, that may never change about you. So methadone.
Are you recording?